We're here today with Dr. Ellis and Dr. Bakeen, who are both experts in coronary artery disease and management of coronary disease, to answer questions that were sent in by our audience on the topic. And we're going to focus on the second part on treatment options. So welcome to both of you. And we're going to start up with some questions starting with treatment. And I'm just going to go through some of these questions. The first one is about treatment or innovation. The person says, for arteries that are shriveled up and cannot be stented or bypassed. Dr. Ellis, do you want to start and then?
It's a little hard to know what to say there, Betsy, because I think you need to see the heart catheterization to know what shriveled up actually means. I might interpret it, for instance, as just a totally blocked artery, which sometimes can be either opened with a stent or bypass surgery. If patients are totally can't have either of those options and are refractory to medication, sometimes we use EECP or enhanced external counterpulsation. But again, it's a little hard to know what to say without actually looking at the picture. I think an artery, to some physicians, an artery that can't be treated isn't necessarily the same for Dr. Bakeen and myself.
Do you have anything?
Yeah, I agree with Dr. Ellis completely. In fact, we were just discussing a case before we went on to this podcast. If you look at the cath and you can try and get some cues as to whether that vessel is bigger than it seems on the cath. And one thing that I found helpful that we were discussing was getting a CT coronary angiogram, because that can give you an idea about the dimension of the vessel, about the calcification of the vessel, and whether you have a suitable landing zone. It doesn't have to be a perfect vessel to bypass. We often find just the right piece of real estate to land that bypass on. So yes, I caution that conclusion without careful evaluation.
The next question is about somebody that has a 100% blocked LAD. They've had multiple 8 stents, brachytherapy, and now the LAD is 100% blocked with collaterals growing and told a graft is not possible. What do you say to a patient like that?
Well, I think if they've had that many stents and radiation therapy, that artery is probably shot as far as stenting goes. If they really have no symptoms, then probably it's not worth taking a risk to do anything in terms of revascularization. But if they were having symptoms, I would refer the patient to Dr. Bakeen.
Yeah, I totally agree. I think if they have no symptoms, there's no need to do anything. But if they do have symptoms, then we will get a CT scan to look at the anatomy and suitability of that landing spot. And this patient could be even a candidate for a minimally invasive procedure where we go through a mini left thoracotomy and do a off-pump bypass. It's called the mid-cab or minimally invasive direct coronary artery bypass. But not every patient is a candidate for that. So that is something that we could study and discuss with the patient. But there may be options if the patient is symptomatic. And if there's any question, also a viability study could be done to see if that part of the heart is still alive and would actually benefit from receiving extra blood. Most patients do benefit from revascularization. So these are my recommendations.
We often get questions from patients who've had multiple stents. Is there a time when they should maybe get an opinion about what is the best treatment for a patient? I mean, you two work together a lot when you're discussing patients. How does that work for you in the practice?
Yeah, there's not an absolute number. I think if the patient is having a recurrence in the same spot after at least maybe 2 or even 3 treatments, then maybe that spot's simply not going to respond to stents, and if they need revascularization, then the surgical option is better. I mean, some of our patients might have 5 or 7 stents and they're all open, and that's great. So it's hard to say there's a number, but the more stents you put in, I think at some point you have to say, well, this isn't really working. Maybe there's another way.
Actually, my record of operating on somebody after multiple stents is 52 stents. And I was able to land 4 bypasses way down towards the apex of the heart. And that patient actually did well. Now it depends who's putting the stent and who's the patient. So if Dr. Ellis is putting those stents, you presented your series of the patency or how long they stay open. And in the newer generation stents, they're amazing in terms of staying open for a long time, up to 5 years, with results very similar to actually, if not better than historic data for vein grafts. So again, the operator and the type of stent and the type of disease and the patient can determine how those stents perform. But generally speaking, if a patient is young and they're not having luck with the stents, it's probably better to consider bypass surgery.
Betsy, I think there's another piece to that, and that is the stentor needs to be really careful that they don't put stents so far down the coronary arteries they don't leave any spot for a bypass if the stents reblock. That's a real mistake that we see sometimes.
One person asked, what is the best stent to use to prevent restenosis?
Well, we have
The Ellis stent.
Yes, I don't have a stent named after me. I think there's little to choose between the current stents, quite honestly, the so-called second-generation drug-eluting stents. I think that there's several that are very, very good. And quite honestly, we seldom use, for instance, bare metal stents, and we certainly don't use first-generation drug-eluting stents. We looked for a while at stents that would totally dissolve, as you may know, and at least to date, they haven't worked out so well.
A person asked, they're 71 years old, they had 5 bypasses in 2003, and then in 2017, they had another heart attack. They said the artery in the back of their heart was blocked but was not treated. They're taking Rampril and metoprolol. Is there any suggestions for that?
They don't really mention symptoms, I don't think. If the patient's symptomatic, they certainly should have an updated cath. Oftentimes blocked arteries, whether they're totally blocked or not totally blocked, can be opened with stents. And under some circumstances, they might even be a good candidate for bypass surgery.
Yeah, I agree. I think symptoms in terms of having chest pain, angina, or shortness of breath should warrant further investigation. And if the vessel is small and inconsequential, maybe medical management, but if the vessel is big enough, then Dr. Ellis, interventional cardiologist, will be able to possibly stent that vessel and improve the symptoms. If that vessel supplies a huge territory of the heart and it's difficult to stent or impossible to stent, then consideration for coronary artery bypass is certainly on the table. Now, if the mammary artery or the internal thoracic artery is open, we usually think twice before reoperating, especially if the LAD, the most important vessel, is a big one that wraps around the heart, because studies from this institution showed the surgery can improve symptoms but may not improve survival, because the survival is determined by that vessel bypass with the LITA to LAD or the LIMA to LAD, the mammary to the LAD. So in summary, you got to look at the anatomy, you got to look at the symptoms, and look at the risk-benefit ratio.
Somebody asked about when do they decide to do stents and when to do bypass surgery. This patient has multivessel coronary disease with blockages in the LAD, circumflex, and RCA.
Well, there are a number of things that should be considered. First of all, I think it should be a joint decision between the surgeon, the interventionalist, and the patient, because there are a number of things to look into. But sort of the main things that we look at are how many blockages are there, where are they located, are they stentable, and particularly if the patient has diabetes, then in general surgery is preferred.
I agree with Dr. Ellis. I think in diabetics, and in general, the higher the atherosclerotic burden, meaning the burden of disease and the distribution of the disease, the more likely surgery becomes the preferred option. But again, it's all risk-benefit ratio and discussion with the heart team to make the best possible choice of therapy.
A patient's brother was a smoker. He has COPD. He was told he needs coronary bypass surgery, but would be high risk. Disease in 2 main vessels. He takes 5 nitro a day. What should he do? Well,
it depends how bad the COPD. 20% of our patients have a documented history of COPD. It depends, are they on any medications such as inhalers? Are they on nebulizers? Are they on steroids? What's their performance status? Can they go up 1 flight of stairs without being short of breath? These are the kind of questions we look at. We look at the pulmonary function tests, and we look at the patient, and we get a CT scan to look at the lung parenchyma, meaning the lung tissue, how much destruction there is. But generally speaking, it's not an absolute contraindication for bypass. But we have to assess the severity and the performance of the patient before we determine the risk and whether that risk is worth taking. Stopping smoking is important. It's critical, in fact. Yeah.
Well, you mentioned a minimally invasive bypass approach. A person they need to be on bypass or need a bypass, and they want to know if they need to be on the bypass machine and if there are minimally invasive options for them.
The debate about whether using or not using the heart-lung machine is the best way to go, it's just controversy that is ongoing. There's no evidence that doing the procedure without the heart-lung machine is better than with the heart-lung machine. Our preference, and the general preference actually at this point in time, is using the bypass machine. It's very safe. It allows a bloodless field. It's still hot. It allows for perfect and complete revascularization of the heart. Now, there are situations where doing the procedure without the heart-lung machine makes sense. For example, somebody with a bad aorta that you don't want to manipulate, somebody with liver disease, a patient who needs 1 or 2 bypasses in very accessible and sizable vessels. Those are situations where it makes sense to do the off-pump procedure. Now, minimally invasive procedures generally entail going through the side, and they can be done either hand-sewn or with robotic assistance. And it's typically offered for patients with an LAD lesion, which is left anterior descending artery, the artery that supplies the front of the heart, the most important branch. And it depends on the anatomy again. If somebody's super obese, if there's chest wall deformity, if the vessel is too deep or too small, they may not be candidate for minimally invasive options. Experimentally, or in certain centers, more bypasses are done in addition to the LAD through a small incision. But frankly, we don't have the numbers or the data to support their safety or efficacy or long-term durability.
This gentleman's dad is diabetic. He's been diabetic since 15, had multiple surgeries and procedures on his legs to improve his feet circulation. Now he has bad blockage in his heart. He has chest pain. His doctors feel he cannot have heart surgery because there are no grafts for him. Are there other options?
So it seems to me like they've used the veins in the legs. So in this patient, the conduit limitation makes the procedure interesting and certainly risky in the sense that you need to have enough conduits to do enough bypasses to achieve complete revascularization if possible. So what we would do is that we will do a vein map, we'll do an ultrasound of the legs to look and make sure that we have absolutely nothing to go for, because sometimes they use the greater saphenous, but they don't use the lesser saphenous, which is the back of the leg. That is something that we could harvest. We could look at the radial arteries in both arms. Hopefully the cardiologist would have cathed them through the leg, because if they cath them through the arm, we have to wait at least 3 months after that cath to be able to use that arm vessel. And so we look at both arms, and then we use both arteries from inside the chest. These are usually the conduits that we use. Rarely we go into the abdomen and take what's called the gastroepiploic artery, which is the artery that supplies the stomach. And finally, as a desperate measure, which I don't recommend, is we use a cryopreserved vein, which is vein from another human being that has been frozen preserved. So the answer to the question is we will look hard to find the conduits, and sometimes if they're not perfect, we'll cut them, splice them, join them together, or take them off each other, what's called a composite graft, to make it work. And if we absolutely can't find the conduits, then we'll send them to Dr. Ellis to try and stent them.
But I think it's fair to say that for somebody that hasn't had prior bypass surgery, it's very unusual not to have conduits if all you need is an LED.
If it's just a single vessel, I've certainly never run by this scenario. I think you'll always find one to use. They haven't had previous heart surgery, and unless they've had a chest deformity or an accident or a previous surgery, I don't see why we can't find a vessel to bypass.
Do you ever stent to open up a blocked bypass graft?
That's an area of some controversy. The short answer is yes, but there is some risk of dislodging the plaque as you open it up and having the plaque embolize into the heart and causing a heart attack. So it's technically feasible, but probably only should be done under somewhat rare circumstances where there aren't any other good options and the patient's quite symptomatic.
A patient says that they have a stent in their RCA that's 10 years old and now blocked, and they have no angina. They think they have plenty of collateral flow. What options are there to reopen the stent, bypass, and or build more collateral?
So in the absence of symptoms, it's probably not worth taking the risk of trying to do something with that. The success rate of opening up total blocked stents with another stent is, at many institutions, is quite high, although it varies a lot around the country. And again, the patient might be a candidate for surgery, but I would say generally in the absence of symptoms, probably should just be treated with medicines.
What do you do for somebody that has chest pain and an anomalous coronary artery recently diagnosed?
Depends on the anomaly, is the answer. Some of them are best managed with surgery, some best with stenting. Generally, there is a treatment option, right, but it depends on the anomaly.
Yeah, I mean, if they're symptomatic, I mean, some patients are at increased risk for sudden death because of those anomalies. What we usually do is a CT coronary angiogram to really delineate the anatomy, and then there are proven and standard surgical techniques to correct this problem. So it's certainly worth treating.
So the main concern is an anomaly that runs between the aorta and the pulmonary artery. It can get squeezed. So in that circumstance, we often treat even in the absence of symptoms because of the risk of sudden death. An anomaly that doesn't run between those vessels is typically not any more risky than an artery that in its more usual location.
If somebody had stents and they closed and then they had cabbage surgery 6 months ago, what's the chance they will close up to?
Sometimes stents do not work well for certain patients. Maybe the runoff of the vessel is not that good. Maybe the bypass vessels might be more durable. Certainly, if it's an arterial graft that's used, that's good quality. So I wouldn't worry about it. I would just see how things go, and if they develop symptoms, they can be reinvestigated. But there's no correlation that if the stents went down quickly, then the bypasses will go down quickly, unless that target vessel is small and heavily diseased, and no matter what we do, is not helping.
So we talked briefly, or you alluded to our studies about the durability of stents, and I'll make the point that the average stent that we put in this institution lasts about 12 years. What is the risk of closure? We often say patients are cured after surgery, and I'm not trying to belittle surgery at all, but what do you tell patients about the risk of the bypasses closing?
Well, the one that we know stays open for a long time, and I usually say if you leave the OR with an open mammary or internal thoracic artery to LAD, then it should stay open for life. And that's generally held true because the patency at 20 years is about 90%. And maybe some of those 10% that went down, many went down early on, maybe related to technical issues. Now, the vein grafts are interesting. Why? For two reasons. One, they get affected by atherosclerosis, unlike the internal mammary or internal thoracic artery, which is usually immune to atherosclerosis. But also, the veins can go to suboptimal targets. I mean, oftentimes, you come out of the OR, you say, oh, I did 4 or 5 bypasses. 2 of them go to really marginal vessels, but, they're sizable enough you thought that they could benefit from a vein graft. And that vein graft does a good job because they do stay open. But on average, at least historically, we don't really have up-to-date data. We know that half of them are going to be down by 10 years. Now with optimal medical management and statin therapy, many believe that we're seeing less and less vein disease. In other words, if you put a good quality vein on a good quality target vessel, and you stick to good medical regimen, then that vein might stay open longer than we thought they did, meaning that they might stay open beyond 5 to 10 years. We can discuss more about the different type of conduits, radials, for example, from the arm. There's recent data that show that they stay open longer than veins. Some people advocate using arm block vein and no touch technique, meaning that you go back to the old days with a big incision and strip the vein with everything surrounding it. And some have advocated doing that and achieving patency rates similar to arteries. But that's probably beyond the scope of our discussions. I think, to summarize, the gold standard is the internal mammary artery to the LAD that stays open for a long time. But veins, it depends on the patient, the target vessel, and the vein itself, the quality of the vein.
There's quite a few questions about post-procedure, how to stay healthy longest, how to prevent future disease. Maybe you both can talk about what your typical medical regimen and advice is for patients after stent and then bypass surgery.
We sort of touched upon this in the first session, but it's certainly worth repeating. So this would generally involve a referral for cardiac rehabilitation, where they'll focus on diet and exercise, and diet and exercise are very, very important. You need to manage your risk factors as best you can. That means getting the blood pressure down, making sure you're not a diabetic, or if you are a diabetic, treating it, not smoking, getting your cholesterol down. All those things are very important. In terms of the medications, the patients are typically on aspirin and Plavix or aspirin and clopidogrel for a period of time after stenting. That period depends on the patient's clinical presentation. It could be as short as a month or as long as forever. And there are a lot of nuances in between.
I think recovery after heart surgery is kind of similar, overlaps in terms of the importance of medical management and secondary prevention, because you want to have those grafts stay open for a long time. So controlling your lipids, your glucose, your blood pressure all contributes to a durability of your bypass procedure. In terms of recovery, you know, when you break an arm, you put it in a cast for 8 weeks for the bone to heal completely. When we split the bone in the middle, we put it back together with wire, and we've used the wire for many, many, many decades, and they're very effective in terms of putting the sternum together and allowing it to heal. But we don't put you in a cast like that for 8 weeks. We ask that you be careful for 8 weeks, meaning to hug yourself when you cough or hug a pillow, and avoid strenuous activity or heavy lifting. But my father had heart surgery, and he went back to desk work within 2 to 3 weeks. And indeed, you know, you'll be out of bed the next day, and you'll be able to do the activities of daily living, but no strenuous activity, typically for 8 weeks.
After you're treated and you haven't had a heart attack, but you've been treated for your coronary disease, are you considered to have heart disease for the rest of your life?
Yes.
So those things that you're suggesting is not just for recovery, it's really a lifelong.
It's a chronic illness. It needs to be managed with an eye for the long term and not just the short term.
I agree. Just take care of yourself, and the better you take care of yourself, the better the long-term outlook.
Well, thank you both for being here today and answering a lot of questions. I know people will be very happy to listen to your information.
Thank you.
Great. It's our pleasure.